the emoji reactions and the chat function for you to post your questions to speakers. So rather than waving hands or trying to butt in, please put your questions to speakers as they're speaking in the chat function, and then I'll put those questions to the speaker at the end of their presentation. If we don't get time for your question, we'll do our best to get back to you with an answer from the speaker after the conference. In order to save time today, I won't be reading out the extensive and very impressive bios of our speakers when I introduce them. This information is on the conference website and the link will be in the chat box. Now feel free to get social. Tweet us at #RAM2021 and let's start a conversation. If you have problems or technical difficulties, or you have feedback on our conference, please send a message to our wonderful tech person, Netanya, via text or email, netanya@monashrotaract.org.au. At the end of today's session, we'll be showing the winning short video from the RAM Annual Schools Malaria video competition. It's from a primary school in Colombia and it's well worth watching. Now, to kick things off today, let me introduce RAM Australia National Manager, Dr. Jenny Kerrison, to provide an overview of RAM. Jenny, the floor is yours.
Thank you, Andrea. Appreciate the introduction and setting out the day. I would like to share very quickly a few slides and to set the context for today. Hopefully you can see my, okay, going up to the top. So good morning, everyone, and thank you for your attendance. Thank you for the continuing support to RAM, in particular from our RORC's chair, John McLaren, Dave Pearson, and many other board members, our RAM committee members, Rotarians across Australia, researchers and friends. Welcome to our 13th annual RAM conference, as Andrea said, so my welcome to you. The conference has had to go virtual the last 2 years due to COVID-19 pandemic. RAM Australia is a national network managed solely by volunteers, Rotarians mainly, and is governed by Rotary Australia, World Community Service, RORCs, and our chair, John McLaren, will talk to us in about 4 minutes. Briefly, I'd like to just set the scene. RAM supports 5 partner countries, and you can see them just north of Australia: Vanuatu, Solomon Islands, PNG, Timor-Leste, and West Timor. We want to be the prime focal point for Rotarians in malaria work in our region. The efficiency would work if we could all go through RAM, and we have the expertise there. We want to provide quality assistance to Rotarians and our partner countries. We want to make international service for Rotarians appealing and satisfying by offering quality country-specific malaria elimination projects. Our goals, 4 key goals. We want a very strong RAM National Committee with financial and technical capacity. We want to support malaria elimination in our partner countries. To do that, we need to be a focal point to provide coordination and advice. And we want to increase a pool of malaria experts in our partner countries by offering RAM PhD scholarship every 5 years, but that may change to just top-ups every year. And we have been able to achieve many of these goals over the last 2.5 years. We have done quite well in regards donations from Rotarians across the country, and we've also boosted our funds dramatically by Rotary Global Grants. So I urge you to join us to experience international service with RAM. And I know together we can end malaria in our region and in our lifetime. because we know Timor-Leste is very close to malaria elimination. Just very quickly, a few slides from our countries.
I thought I better take the bloody box, right?
West Timor. I don't know if Peter Mackenzie is here, but we had a really good trip out to West Timor last year. Vanuatu, Solomon Islands. And Rotarians, let's travel together. Thank you.
Thank you, Jenny. And could I just remind people, please, to make sure that your audio is muted today. It's now my pleasure to ask past District Governor John McLaren, Chair of Rotary Australia World Community Service, RAWCS, to officially open the conference. John, over to you.
Thank you very much, Andrea. And it's really great to see so many individuals and organisations from across Australia at this Rotarians Against Malaria 2021 conference. The fact that it's virtual is another one of the really wonderful ways that we've been able to use technology. You see, I attended the first of these conferences 13 years ago, and it is wonderful to now see so many people interested in the eradication and prevention of malaria. This conference has become the Australian venue for sharing malaria research at one end of the spectrum to, at the other end of the spectrum, updating ourselves on the on-the-ground efforts that are reducing the incidence of this devastating disease. The conference is organised by Rotarians Against Malaria, which is an activity of Rotary Australia World Community Services, or RAWCS, as Jenny has explained. RAWCS is the Australian Rotary company that supports Rotary clubs to assist disadvantaged communities and individuals through humanitarian aid projects. RAWCS was born out of a project in Indonesia some 57 years ago. Today, the organisation has developed to be an integral part of Rotary in Australia. As you know, there are over 1,100 Rotary clubs right across Australia and more than 30,000 Rotarians who form part of a huge network of business and professional people who are dedicated to improving the lives of those less fortunate than ourselves. Rotary is all about treating one another with respect and adopting ideals to promote goodwill and fairness. These ideals manifest themselves in Rotary's motto of service above self. I'll get this one. RAWCS is the jewel in the crown that turns dreams into action. In many respects, RAWCS is the back office that enables Rotarians to undertake all manner of humanitarian projects. We help people we will probably never know or meet. It might surprise you to learn the extent of what RAWCS does. We are currently involved in 387 projects in 130 countries, undertaking a vast range of projects from health and education through to environmental and water and sanitation programs. At home, last year, we supported 104 compassionate grants to Australians in need. We also conducted a number of appeals for disasters both here and overseas. But as the man on the TV says, that's not all. We have been helping the Australian government to provide community outreach events and to distribute gift vouchers to farmers and those impacted by drought. This program reaches into the most remote parts of Australia and is delivering millions of dollars of assistance to a sector of our community that we all rely on. We have partnered with the National Recovery and Resilience Agency, the NRRA, to use our Australia-wide network to assist all those who each year are impacted by drought, bushfires, floods, cyclones, and other disasters. All of this work is undertaken through 4 activities. Projects. Projects provide volunteer teams and/or funding for Rotary projects undertaken locally, nationally and internationally. Repurposing, reusing and recycling health and education equipment. Well, we collect and transport surplus goods and equipment from Australia to where it is needed overseas. Communications. We deliver Rotary in action to the public, the corporate sector, philanthropists, governments, and to Rotarians and Rotary clubs. And last but not least, Rotarians Against Malaria. As you know, we provide supplies, equipment, and volunteers to support the elimination of malaria in our region by 2030. We do all these things through some tax-effective structures, which means that that donors can get a tax deductibility for their donations. Each year, we have provided millions of dollars of financial assistance here and overseas, thousands of volunteer hours, and millions of dollars of donated equipment to communities and individuals. We encourage Rotary clubs to use Rorks because we have online systems that deliver nationally consistent project management in line with the ethical behaviour and values of Rotary International. We provide Rotarians and their project partners with tax deductibility for donors, project accounting, internal audit, and secure international currency transfers at low rates. Rorks has comprehensive Australian government registrations providing regulatory compliance for all our projects. And Rorks promotes Rotary through nationally recognised high-profile projects, advocacy and marketing. So now you know a little bit about our organisation. Let's have a look at what Rotarians Against Malaria have been doing. Since 2015, progress in malaria elimination has been at a standstill across the world. The latest malaria statistics from 2019 indicate that there were over 200 million new malaria infections and over 400,000 malaria deaths in 2019. Children under 5 years of age in sub-Saharan Africa continued to bear the brunt of disease. However, we are fortunate that our partner countries, Timor-Leste, Vanuatu, the Solomons and Papua New Guinea, are leading the way in their quest for a malaria-free status. To support this, RAM is seeking to raise awareness of this goal through the Rotary world and in the wider community. The RAM team, as Jenny has indicated, have obtained 4 Rotary Global grants that raised an additional 328,000 Australian dollars for 2021-22. This is on top of the completion of a US $250,000 Rotary Global grant in Timor, which concluded in May 2021. In Papua New Guinea, malaria is still on the rise. The new National Malaria Strategy Plan for 2021 to 2025 aims to reduce malaria by 63%, with malaria elimination in some geographic areas by 2025. Malaria is a leading cause of absenteeism in schools in Papua New Guinea. To address this problem, RAM PNG initiated the Chasing Malaria program, a community-based intervention to bring malaria testing and treatment closer to communities. You'll hear more on this during the conference. RAM Australia has also provided a sizable donation to this program. In 2020, the Solomon Islands had approximately 111 cases of malaria per 100,000 people. RAM Australia and partners have developed a project for Honiara that will establish surveillance teams for active case detection to test and treat uncomplicated malaria in a population of 8 to 10,000 people. In Vanuatu, there were 1.7 million cases per 100,000 population in 2020. With support from RAM and partners, Vanuatu has commenced a project that will train and equip trainers and supervisors for the National Indoor Residual Spraying Program. In Timor-Leste, they reported 0 indigenous malaria in July 2017. Unfortunately, in 2020, 3 local transmissions of malaria were reported at a border district. RAM Australia purchased 45,000 bed nets for pregnant women and 80 sprayers for indoor residual spraying. A total of 35,300 odd houses were sprayed with insecticide, and around 166,000 people were provided with protection. A new Rotary Global grant commenced in 2021 to prevent the re-establishment of malaria in this part of the world. West Timor, Nusa Tenggara Timor, or the NTT province of Indonesia, aims to achieve a malaria-free status by 2026. A Rotary Global grant, which commenced in 2021, will accelerate malaria elimination in West Timor and prevent cross-border malaria transmission into Timor-Leste. The project will train 12 village malaria cadres in one border district to test and treat malaria in line with Ministry of Health regulations. In 2020, RAM formed a collaboration with the Global Fund and RAM to finish the fight, with the aim of raising $12 million US for the elimination of malaria in the Western Pacific Rim. You'll hear more of this during the conference. Your interest in eradicating malaria from our region by 2030 is a key focus of Rotarians across Australia, and I am sure that the information and sharing that will occur over the next few hours and tomorrow will strengthen our ability to achieve our 2030 goal. I have a great deal of pleasure in opening this conference and welcoming your participation, and I urge you to redouble the efforts to defeat a disease that has been around throughout our recorded history. Thank you very much.
Thank you, John. It's always good to hear about the wider RORCS world, and to know that RAM can play an important part in that, and we certainly appreciate the support that we get from RORCS. There was a question in the chat from Graham Jones: how many RABS projects are currently underway via the RORCS structure? John Stockbridge has provided an answer to that, saying we're supporting around 150 RABS projects in Australia, and we hope to increase this dramatically over the next 2 years by being able to support Rotary clubs with funds donated by philanthropists and corporates. I don't know if you want to add anything to that, John?
No, that's fine. Thank you very much, Andrea. And thank you, John.
Okay.
Thank you. Andrea, could I just butt in here? I apologise, but I think it's important that people know that I'm the timekeeper, and that when the 15-minute presentations are started, after 13 minutes, I'll give you a 2-minute warning. So just thought I'd out of courtesy, let everyone know.
Thanks very much, Gloria. Appreciate that. So speakers, remember, yes, Gloria will be monitoring that you keep to time, and that's very important because we do really have a very packed program. Okay, I'd now like to introduce Camilla Burkot, Technical Advisor to the Ambassador for Regional Health Security and Principal Health Specialist in the Indo-Pacific Centre for Health Security. Camilla's presentation is Key Issues Impacting Malaria Elimination in our 5 partner countries. So Camilla, could I ask you to take the floor, please?
Thank you very much, and let me just check that you can hear me okay.
Yes. Yes,
great.
Thank you.
And thanks, Natanya, for loading up the slides. Good morning, everyone. Before I start, I would also just like to acknowledge the Ngunnawal people who are the traditional custodians of the land on which I'm sitting here in Canberra. And I'd also like to extend that acknowledgement and respect to any other Aboriginal and Torres Strait Islander people who may be joining us today. Thank you very much for the opportunity to participate. My name is Camilla Burkot. I work with Dr. Stephanie Williams, who is the Ambassador for Regional Health Security, and who sends her apologies. She wasn't able to attend today. For those who may not be aware, the Indo-Pacific Center for Health Security is a whole of government center which is based in DFAT. It was established in 2017, and we have responsibility for implementing a range of government initiatives to do with global health security and also more recently COVID-19 vaccine access. So today I will be talking a little bit about what we see as the sort of key contextual and technical challenges that are affecting progress towards malaria elimination in our near region, particularly in this context of COVID-19, what the Center for Health Security is doing to support progress towards malaria elimination, and what our plans look like as we look towards 2030. Next slide, please. So before I turn to those challenges, I thought it might be useful just to give a very brief background in terms of what DFAT's investments in global health have looked like. So in the years prior to the pandemic, we were averaging about $500 million per year out of the approximately $4 billion ODA, Official Development Assistance portfolio towards health projects. Of that, around 40% went to global and regional investments, so investments in WHO, in the Global Fund, Gavi, those sorts of things, and around 60% in our bilateral or country programs, and programs such as those that we run through the Center for Health Security. And actually the largest proportion of our budget, even before the pandemic, was going to disease control and preventable disease objectives. Obviously, since 2020 and since COVID-19, there has been quite a significant shift of the development program as a whole to respond to COVID impacts. Around $300 million were shifted or pivoted to COVID-related projects from within the existing development budget. We invested about $20 million in various health responses, including outbreak responses in places like PNG, Timor, Fiji, and a range of preparedness activities across the Pacific Islands and Southeast Asia, things like PPE, diagnostic equipment, and technical advisors. And I've just put a link on this slide. We have a couple of trackers on our website that you can look at and go through by country and see what the various investments have been made, both under the Health Security Initiative, but also our partnerships recovery and the sort of COVID-19 response. Since last year, we've also been delivering the Regional Vaccine Access and Health Security Initiative. This is a $523 million initiative to deliver vaccines and associated support to 18 countries across our region, including all 5 of the countries of interest to RAM. So far, we've delivered 7.2 million vaccines with a commitment to deliver at least 60 million over the coming year, a little more than a year. But even throughout all this activity that's really ramped up due to COVID, we've continued our engagement on malaria in a range of fronts, including the Global Fund. We are represented on the board, and we've invested part of our set-aside funding, which was announced last year at the Australia-ASEAN Summit, towards some laboratory capacity strengthening projects to support improved malaria diagnosis in several countries, including PNG and Timor-Leste. And we continue working with organizations such as these Asia-Pacific Leaders Malaria Alliance, Medicines for Malaria Venture, Foundation for Innovative New Diagnostics, and others. So all that to say, there has been a lot of activity. The shape and the energy that's been put behind global health at DFAT has shifted a lot in the last year, but we continue to be quite engaged in the broader global health issues. We recognize the need to keep a wide focus and to ensure the continuation of essential health services and addressing diseases, a range of other diseases, including, very importantly, malaria. Next slide, please. So what are some of those key issues and challenges that we expect may have an impact on progress towards malaria elimination? I've split this up into sort of to two categories. So we have the political contextual issues, and then I'll talk a bit more about the technical issues. So on this political contextual side, you know, we know that malaria elimination by 2030 was already a challenge. It's a major challenge, and that existed prior to the pandemic. COVID-19 has really exacerbated this to a range of degrees, noting that countries in our region have been affected to different degrees by COVID. What we have found over the last year, it has been difficult to get the attention of health ministries on this issue, particularly in smaller countries, simply because there's just not very many people working in health, and they've been very busy with COVID, either preparedness or response, depending on the situation in that country. Likewise, we know, you know, malaria elimination is not just an issue for health ministries, it also requires engagement of finance and treasury, the whole of government responses, as well as other development partners, and across the board, everyone has been very stretched. So the capacity to get attention has been challenging. We're also concerned about the potential for weakening of political will and government leadership to eliminate malaria. And again, we know COVID's going to remain on the agenda for quite some time to come, particularly in those countries which haven't yet been able to raise their vaccination rates as high as, you know, ideally we would like to see. So there's going to be a long tail with you know, for the COVID response. In addition, we know, of course, that COVID-19 has had profound economic impacts, and the implications of that may be reduced resources available to commit to malaria elimination. And we know this is an issue that will both affect domestic budgets for partner countries, but also potentially development partners and donor budgets. We know that, of course, you know, the Global Fund grants have continued during the pandemic. In fact, Global Fund has been very active, has really leaned in and supported countries. But we are cognizant of the risks around the Global Fund replenishment that's due to happen next year. And as I said, those pressures on domestic budgets in partner countries. And then I think a third sort of major issue that will present challenges potentially to the progress of malaria elimination is simply the level of fatigue that's been experienced by health systems and health workforces, particularly in those countries which have been harder hit by COVID, so PNG, Timor, Indonesia. And I think there's a couple of dimensions to this. You know, in practical terms, health workers either maybe have been pulled away from their normal duties. We've of course lost, very sadly, very many health workers in some countries. But there's also a broader impact in terms of the systems, in terms of the impact on strategic vision and ability to think beyond business as usual. And we know that's what's required to get to malaria elimination. And there's also the level of operational support. So we need frontline, we need clinicians, we need frontline health workers, but we also, malaria elimination also requires a strong backbone of management and logistics, and having that both not just at the national level, but at the subnational level. And there's also an issue tied to that to do with even the ability to absorb donor financing and and domestic financing as well. If you don't have those systems and people in place, it can be very challenging to move forward. Next slide, please. On the technical side, there are a range of challenges which exist to varying degrees in each country. And I know that the conference agenda features a number of technical specialists who will be presenting over the next 2 days. So I'm not going to go into a lot of detail here, but just briefly to sort of sweep across some of the main ones. You know, access to diagnosis and treatment in a very timely way is absolutely critical. And that's particularly for these countries, access to relevant solutions for Vivax malaria and for diagnosing G6PD deficiency. And we know that, as I said, that's, you know, this rapid access to appropriate treatment is important, not just for protecting people's health, but also reducing the opportunity for onward transmission of malaria. And that's what we need in order to get to elimination, is to break those cycles and reduce transmission. There have been concerns about the efficacy and the durability of some of the tools that have been used, whether that's the efficacy of bed nets in PNG, also issues around behavioral resistance. Are we using the right tools? What are the vectors and the parasites? How are they responding to the tools that we are using? And that's something that we've seen in Solomon Islands. Surveillance is a really big one, and I'm glad that's already been mentioned this morning. Being able to monitor and use data for decision making, which is particularly critical in a near elimination context. We really need to be able to identify and extinguish those outbreaks very quickly. And I think, in addition to the near elimination context, also relevant to that, of course, is ability to share data across borders between countries. And when I talk about data, we were thinking both in terms of epidemiological data, clinical data, but also entomological surveillance and data. And lastly, I mentioned drug resistance. This isn't a huge issue in our region, certainly compared to other parts such as the Mekong in Southeast Asia, but it is a risk. It's linked potentially to access to health services and appropriate commodities, and so it's something that we need to continue to be aware of. Next slide, please. So what is the Center for Health Security doing to contribute towards malaria elimination? As I mentioned, we, under the Health Security Initiative of the Indo-Pacific, the first phase is a 5-year phase of funding. So we're nearing the end of those first 5 years, but we've invested sort of in a range of ways. So we are supporting the development and the deployment of safe and effective tools through investments in the Global Fund, of course, and that includes the core funding that goes to Global Fund to support country programs, but also through engagement in various parts of the architecture of the Global Fund. For example, in Southeast Asia through the Regional Artemisinin Initiative, and we are really trying to use our influence through those sort of mechanisms and through the board to try to make sure that when there are opportunities to use catalytic funding to promote regional initiatives or regional priorities, that those are at the table. We've also more recently had input into the Global Fund's next strategy and have really worked quite hard to ensure that it remains responsive to the near elimination settings, not just high burden settings in places such as sub-Saharan Africa. So that's really important for countries like Timor-Leste, as mentioned, and Vanuatu that are getting closer to elimination. We want to make sure that the Global Fund is still serving the needs of those countries and is acknowledging the needs of countries in our region. We also invest in product development partnerships, such as I mentioned, MMV, FIND, and IBCC. And we've, in this most recent phase of investment, we have worked quite hard to try to make sure that those partnerships are engaging more directly in our region. For example, through IBCC has projects now working with PNG IMR and other partners in PNG. So that's sort of, we're investing in in the development of a range of tools, but we know that each country that has been successful in eliminating malaria so far has had to find its own unique pathway there. We can have universal tools that work well, but there isn't necessarily one universal formula for applying them. So,
excuse me, Camilla, 2 minutes. Excuse me, Camilla, 2 minutes.
Thank you. So we've got a range of projects at the country and the regional level, which are looking to address some of these specific technical challenges and build local capacity and test implementation of solutions. So to give you some examples, there are projects through the Burnett Institute, through Menzies, through JCU and Doherty Institutes on vector-borne surveillance, implementation of radical cure, modeling for malaria elimination. We're working with the Therapeutic Goods Administration to support countries to be able to evaluate and approve new tools, such as tefenoquine for Vivax. And we continue to have DFAT staff that are participating actively, as I said, in some of those country coordinating mechanisms, technical working groups, to help us really give us insights to inform their investments, to advocate at the global level for the particular needs of countries in our region. And we continue to work to sustain political commitment. We remain a core funder of the Applemus Secretariat, which is working with countries to build political will at the regional, national, subnational level. And I'll just highlight briefly because I know cross-border elimination is a particular interest, that APLMA will be presenting a high-level meeting on malaria elimination in December, which is going to have a focus on cross-border engagement. And I know that APLMA is now working with RAM on that issue in Timor and Indonesia. Next slide, please. So just briefly to wrap up, as I mentioned, first phase of CHS is due to conclude the middle of next year, though a number of those projects will continue on. There's currently consideration of future funding, continuation of funding. That will be a decision for government, but we do expect and would advocate for malaria and vector-borne disease being a priority in any future continuation of the Center for Health Security. We really keeping in mind a number of key principles that will be important for supporting malaria elimination towards the future, thinking about high impact, low cost, evidence-based, community-based interventions, which I know Professor Whittaker will talk about next, looking at how we can be efficient, where we can address multiple diseases at once, and really continue to support champions to lead malaria elimination. And lastly, just to say, I think there is cause for optimism. The Global Fund results report this year showed that malaria programs have resilience. The RTSS vaccine approval, while it's not likely to play a major role in elimination in our region, is an important breakthrough. It's an important symbol. It gives us renewed energy in the fight. And again, it has been mentioned, there are countries in our region that are getting close. So we need to continue to push forward and help them to get there. And I think I just have a thank you slide next with some links where you can find out more about what we do. So thank you again for this opportunity, and happy to take any questions.
Thank you, Camilla. That was great. It was really interesting to hear what DFAT's doing. We do have a question, and I guess it's a question that I was going to ask if nobody else did. What's the cooperation between DFAT and RAM, and how can RAM be most useful and effective in our efforts and working with DFAT in the region in particular?
Yeah, no, thanks very much for the question. And as you know, as I mentioned, I think partnerships are really important for us, and we have a range of different partnerships. We have funding partnerships, but we have lots of partnerships with organizations, and what is often referred to in sort of DFAT speak as people-to-people links. And we recognize that's really important. So we don't have a direct funding relationship with RAM in terms of malaria, but we really value the contributions that RAM's making. We would be really keen to continue to have regular information sharing. Opportunities like this conference are really important for that. I think another thing that's really important and would be useful for us in terms of working together and mutually maximizing the effectiveness of our investments is ensuring that we have connected up with our posted officers. I mentioned at our various embassies and high commissions in the region, those health officers are engaged on the ground with health ministries, with those country coordinating mechanisms, and a range of ways that they engage with government. So building those links where they don't exist already between RAM and the relevant people at post is really important, because that ability to share information and make those connections is we find is really valuable, and we really welcome that type of engagement.
Thank you. Oh, look, I might come and take you for a coffee sometime in Canberra, because I'm just at Queanbeyan, so it's nearby. Another question from Jenny Kerrison. What's DFAT's role in ensuring access to diagnostics, for example, between big donors, such as the Global Fund, to increase the, let's see, what are we looking at? G6PD not available in PNG, and purchases not arrived in the Solomon Islands. Does DFAT have a role in that?
It's a good question. So I guess our engagement with Global Funds, as I sort of alluded to, exists on a couple of levels, sort of at the global level, but then we have some engagement with the various country coordinating mechanisms. And then, but I guess there's a challenge too in terms of the sort of the broader architecture and countries' ability, to have they've approved the tools. Do they have a plan for rolling them out? So it's a bit difficult to talk in generalities, and I'd be happy to kind of maybe go away and talk to a few people and sort of try to get a clear answer for you. But I think, you know, where we're aware and where we have direct engagement with the relevant groups on the you know, the CCMs or the Ministry's Health on the ground, we work to help support development of plans and participate in some of those guiding discussions. But I couldn't speak to specifics for PNG and SOLs. I don't have enough information personally, but happy to sort of take that away and find out a bit more.
Thank you. I think that's about it for questions. Thank you so much again, Camilla, for your presentation. That's been really interesting, very useful food for thought. And yes, I'm quite serious about getting in touch and taking you for a coffee. So I hope you don't mind if I.
That sounds great. Thanks very much.
Thank you.
Thank you.
Our next speaker is Professor Maxine Whittaker, Dean of the College of Public Health, Medical and Veterinary Sciences at James Cook University in Queensland. Maxine will be speaking on the role of community and civil society involvement in malaria elimination. So Maxine, over to you.
Yeah, thank you very much. And just to also note, I actually retired 2 weeks ago from my Dean position, but had a great time in doing so and still am engaged. Before I start, I'd like to acknowledge the traditional owners of the land on which I'm speaking to you today, the land of the Gubbi Gubbi people, and pay respect to their elders past, present, emerging, and also respect to any Indigenous peoples listening in today or on the YouTube clip. What I was asked to talk about is around civil society roles, and I'm particularly going to focus on the Greater Mekong sub-region, where I'm now doing quite a lot of pro bono support to them in my Renaissance years. And I'll start with talking about the civil society platform for the regional Artemisinin initiative, the third of those, funded by Global Fund in the Greater Mekong sub-region. The malaria-free, they call themselves the malaria-free Mekong. It's a network of all the civil society organisations and communities from the Global Fund RAI implementing countries. So that's Cambodia, Laos PDR, Myanmar, Thailand and Vietnam. And the platform serves as a mechanism to engage with the Global Fund and that granting system, bridging that to the communities, project implementers, policymakers, and the donors. And as you'll see, I'm one of the civil society representatives on the Regional Steering Committee, and we're having a 3-day meeting next week. So it fills a gap in trying to help the civil societies serve their regions, but also that coordination and communication link. So the objectives are meaningful coordination and partnership, advocacy for policy strategies and plans, particularly in community-based services, respecting the rights of all communities in the Greater Mekong, and advocacy about continued financing, but also a continued seat at the table. And to then also strengthen the capacity amongst the civil society actors to be able to leverage their strengths to implement and to leverage with other technical partners around community engagement tools, guidance and advocacy. And I won't go through this in detail, but that's the governance of the platform, and the platform is funded under the RAI 3 grant, and I'll talk a little bit about that in a moment. So briefly, how about malaria in the Greater Mekong? What's the situation? Very quickly, you'll see on this first map, this is for Plasmodium falciparum, you'll see from 2017 through to 2020, a real shrinking of the red areas and an increasing of the green. But you'll see, as I've put arrows on the 2020 map, that still at the border regions, we have a lot of malaria. They're still the hotspots, and that's where a lot of the focus of the RAI 3E grant is paying attention. And you'll see a very similar picture for Plasmodium vivax. Again, the dark blue areas still are some of the same areas, and they're those border areas. Just also, I wanted to show you how some of the organisations, so civil society organisations working with the government in Lao PDR, actually are using mobile phones, you'll see them down there, to transmit their data live on a daily basis into the national information system. So that means that we can actually get real-time data, but also they also get sent back data about what they might need to do, and hopefully this will also link to better logistics support for them. So this is just piloting this year. So this is the funding that goes to the RI, so the Regional Artemisinin Initiative, 3 because it's the third one, and E because it's focused on elimination. This is the Regional Global Fund grant. It's worth $32.5 million US dollars. And here's the split of the funding. And you can see the largest split goes to the package of providing services in those border areas. And that's money that is managed a lot to the civil society organisations working in those. I'll show you those in a minute, but also the National Malaria Control Programs. There's also a package there for WHO in its malaria elimination work, operational research, money that goes to the Geneva office of WHO. And you can see that darker blue area there, package 5.1, is the $1 million that the platform has to do its work. And just an example from Thailand, you'll see, and you won't be able to read this in detail, but I think that pie chart probably shows you that there's 6 major civil society organisations that are supporting the National Malaria Control Program in Thailand to provide services, particularly in those border areas. The next couple of slides will show you where those civil societies are in these countries. So in Cambodia, the red dots are the Malaria Consortia, the green dots are Catholic Relief, and the blue dots are CHAI, the Clinton Health Initiative. So you'll see quite spread around, quite a lot in those border areas, but also in some other areas where there are hotspots or concerns around malaria or malaria drug resistance. In Laos, you see, again, it's really at those border areas. Atapu, which is the bottom one there with the blue dot, is one that keeps often getting epidemic outbreaks. We've had a few of those already this year as well. In Thailand, you'll see, again, very much the dots in the border areas down the bottom there of Thailand, and particularly up in the Myanmar border areas, and also with Cambodia and Laos PDR. And in Vietnam, again, in some of the border areas or the highland areas, so the mountainous areas of the country. And Myanmar has had a lot of its success up till COVID and the political and military actions, has had a lot of its success due to the civil society groups working very closely with the malaria control program of the country. So you'll see several CSO, civil society groups working there in almost all parts, but particularly in the border areas with Bangladesh, with Thailand, with Cambodia, and with Laos PDR. So I just thought I'd highlight, because often people ask me, so what do civil societies do? So I'll just highlight briefly some of the work that they're doing, particularly what we try to identify, and we will be next week to Global Fund, are some of the initiatives that they're making, so that we actually can talk about their role in providing local ways, as Camilla was saying, local ways of dealing with problems. But first, this was the data for the first half of this year. And what I'm trying to show are all the 5 countries there, the total, the suspected cases of malaria that have been tested by the civil society groups. And then in brackets, what that is the percentage of the total reported testing in the country. So that's in the routine health system, a little bit the private sector, but particularly in the routine public health system. And you'll see that in Myanmar, as I mentioned, a large percentage, nearly 63% of all of the testing is being done by civil society organisations. And particularly in COVID and now the military activities that are occurring in Myanmar, if it was not for the civil society groups working often in very difficult conditions, we were hearing just this week or so further death threats against people who are trying to provide services in their communities. They are the ones who are really keeping malaria program as well as the other parts of the health system working. It is Myanmar that we obviously are worried will not reach the malaria elimination targets in the Greater Mekong, but all the other countries feel very much on track. There's smaller numbers there in Thailand in their role. That's because at the moment, but it's changing. We're just hearing about changes that the Thai government's agreed to. There has been a policy against community health workers and volunteers actually doing testing. So they haven't played a major role in that. It's more a referral role. And in Lao PDR, there have been a lot of disruptions to commodity provision. So again, there hasn't been a lot of testing, but also it's about this time of year that they do more of that work. So a major role by civil societies in actually testing and then treating the cases, and then also distribution of long life insecticide nets and hammock nets. So just, again, I'll do a shout out for Myanmar particularly. We're very concerned that the situation in Myanmar and the health and lives of people there are just not getting a lot of international attention in the press, and seems to often be forgotten in discussions about problems in the world. The Medical Action Myanmar is one of the NGOs there. As you can see, a large number, more than 20,000 integrated malaria community volunteers there. They work at the front line in those remote and hard to reach areas. They actually provide a more integrated package, so not just malaria, but also TB case finding and follow-up, referral of people with health emergencies and other basic health services. And that's been part of that real success, and particularly in COVID-19, as I've put on the bottom, they've been the ones often providing personal protection, job aids, information to communities and to the workers. They also have been providing, as I mentioned, during armed conflict, a lot of service delivery despite all of the restrictions that are occurring. And that's because they're very close to the community and many of them don't have to travel. They are of and in that community. And again, Myanmar, you'll just see these dots are all of these integrated community health workers or ethnic health workers around the country. So a very large workforce. And again, some of the work they do the census stuff. They actually do the awareness and awareness training, checking the bed nets and providing forest packs for people who go to the forest, some repellent, some hammock nets, some information about where to go. And they do the screen, test, treat and track. In Lao, again, just a couple of things that they highlighted in their report, particularly in the forest areas, very different types of activities. So in Atapu, which I mentioned before, mainly an ethnic minority, a lot of the people travel into the forests, particularly the males, a large distance and stay there. And that's part of what you see in the difference there of the males, those blue bars in that 10 to 29-year-old age group are the ones who go to the forest. And this is some of the food that they collect to sell in the forest, some mushrooms and some vegetables. But another province there, it's quite a different. The women also travel with the men and their families. So the whole family moves into satellite settlements away from the village during the seasons to actually be part of that forest gathering activities. And Lao itself, the CSOs are involved with others in the operations research, and they're also part of a project about looking at how to actually support these mobile and migrant populations a lot better. There you see one of those insect-treated hammock nets, and you see some of the activities that people are doing in the forest, which also include rubber tapping and other activities. So they're actually looking at how do you actually provide services when people go away from their villages and routine locations. In Cambodia, they're doing a lot of work also to support operations research, extending coverage to those populations at risk, particularly in remote areas, community engagement and social behavioural change messages, and also provide advocacy for malaria in the country across the whole area, help support the government's efforts to keep malaria on the agenda, provide technical support, and, they have regular meetings, the National Malaria Control Program, brings civil society and international NGOs into very regular meetings to discuss the malaria program, and also involved in research and surveillance activities. Raks Thai is in Thailand, and it works in high endemic areas in Ubon Ratchathani and Sisaket, particularly which is the Thai-Cambodian and Thai-Lao borders. These are hard to reach areas. It's very mountainous. There's a lot of migrant workers as well as Thais, who work in the rubber tree and other informal work that happens. Some of that legal, some of that may be illegal. And so the Raks Thai Foundation staff and volunteers collaborate with government partners to actually do malaria prevention activities and have set up at the checkpoints. There are places where people regularly move in and out of the forest, so actually provide services, prevention, screening activities and education at those locations. There are, of course, challenges ahead. We need to ensure that these community systems, not just health systems, are strengthened. You can see they play a major role in control and elimination. And we are concerned that after this third regional grant of Global Fund goes and there's other donor transition, because these countries are becoming middle income, that civil society, which is very much at the table because you have donors and Global Fund engaged and really pushing that agenda, that it will be hard for them to remain at the table when you have that transition away from donor funding. But we also need to make sure that when the CSOs are at the table, they are representing their communities and have accountable and transparent ways of helping make decisions at the table that are not their personal ideas, but the ideas that come from their communities' needs and interventions and contributions.
Excuse me, Professor Maxine, yes, 2 more minutes.
Yes, thanks, Gloria. I'm on my last slide. We also need to make sure that we keep funding at the levels required to eliminate malaria and then eradicate it globally. I was talking to a civil society rep on the Global Fund, who was at the Global Fund board meetings this week, and he was saying that people are still concerned that Global Fund and donors don't realise that there still needs to be a lot of money to keep eliminating. As you can see, it's in those harder to reach areas. It needs very intensive work. It needs house to house. It needs very bespoke approaches to each of those different ethnic populations or disabled peoples or stigmatized groups will need very particular interventions, and that actually requires money. It doesn't mean that there'll be less until we actually eliminate and then eradicate. So I mentioned there is concern that if civil society groups are not actively involved in the agendas, that some of the gender equity, social and disability inclusiveness that's on the country agendas in the greater Mekong area, particularly also because Global Fund pays attention to that very much in their funding, as do other donors like DFAT, that as the donors transition towards more national funding of the program, that some of those agendas may be lost. And again, as I talked about in Myanmar, it is not just the needs for malaria. These communities are not being reached often by any health services. So those communities need and demand universal health care and need to have resilient health and community systems, whilst also maintaining the eye on malaria elimination in their areas. Thank you very much, and I'm happy to take any questions.
Thanks, Maxine. Wow, what a great presentation. And Well, my chat has been exploding with questions from our national manager, Jenny Kerrison. So Jenny, I'll invite you to put the questions directly to Maxine.
Thank you, Andrea. Thank you, Maxine. I just love the topic because it is very important for us to realise that, yes, we have got the demand for services and we've got the suppliers, the health system itself run by the government or governments. I just wondered, you know, you mentioned about strengthening community systems. Now, that is such a new concept to me anyway, because I've worked in international development since 1996. Communities have always been mobilized. You know, the language they use is mobilized and motivated, and usually initiated by local governments and national, and funded by them as well. So how do you see that, you know, for them to gain that independence? I know Global Fund is funding CSOs, for example, in as you've mentioned, as well as in sub-Saharan Africa, and you've mentioned DFAT. How does it work to, what are the systems you have in place to strengthen them? For example, how do you have supervision system of volunteers? The fact that they're volunteers, it's very hard to control. As we know here, Rotarians, we're all volunteers and we can't impose too much on our volunteers in general. Thank you, Maxine.
Yeah, thank you, Jenny. And that probably would be, you know, a good long conversation, which I'm happy to have with people. I am happy. I mean, what I will do, Global Fund has got a document about what they mean about community systems strengthening. But basically, it is, as I said, the resilience, particularly as you get to the end mile, but also as we've seen with COVID-19 and, you know, other things, is the community needs to know how to and be supported on how to itself mobilize its people, have decision-making systems, does try to look at inclusiveness, knows who to go to when they need particular resources. So it's really saying, you know, when we need the community to actually be actively empowered and engaged in malaria elimination, but also in their own health. Not saying that then nobody else needs to worry about it, but they do need to be the people that actually own their own health and their health, have systems that try to bring it to the fore. That's been done quite a lot in maternal and child health. There were things called in Indonesia, Desa Siaga, alert villages, which then became something instead for pandemics. But, you know, they had systems where people could mobilize transport from local areas, had raised some money if somebody actually needed emergency transportation because the woman was having a hemorrhage, et cetera, et cetera. So it's really helping communities set that system up, or systems up. So that's what we're talking about, and it is something Global Fund is supporting groups going around and trying to map how communities are actually working. We're involved with that in the Greater Mekong, so that they can actually see where that strengthening needs to go, but also so that they can have representatives at the decision-making tables, because even though they are at the steering committee and the country coordinating mechanism tables, there's often one civil society rep, and then there's 2 or 3 from the donors, and there's WHO, and there's the UN system, and there's a whole lot of other very powerful people and a civil society rep. So also making sure that they have systems to actually allow them to meaningfully be representative of and be able to speak the needs of the communities at those tables. And I see that there are a couple of questions there around what is Global Fund. Again, I'm happy to put some links to it, but Global Fund is the Global Fund for AIDS, TB and malaria, and it's one of the major funders of malaria, HIV and TB work around the world. In our region, the regional Artemisinin initiative is probably the largest of those grants, but also Papua New Guinea, Solomon Islands and Vanuatu do also have some funding from the Global Fund. And Carolyn's put it up. Thanks, Carolyn.
Okay. if there are no other questions.
Just a quick question. Sorry, Andrea.
Yep.
So Maxine, your platform sounds really well set up and established, and it to me, I'm not sure how long you've been working on this in this platform and shaping it. Do you have similar platforms for CSOs in Indonesia and Timor-Leste? Thank you.
Yeah, thanks, Jenny. The question, I mean, the civil society platform for the Greater Mekong was set up 2006, particularly in the beginning, to help civil societies be engaged in the Global Fund grants and help that collaboration, coordination, strengthening. So it's very much a funded platform. It's hosted by Alight, so the American Red Cross, as just a mechanism. We are talking about, so I've only been involved as a rep this year. I was elected. We had to stand in front of all of the different CSO representatives and present our work and why we might be there. They wanted people who are, it does sound funny, I'm obviously not from the Greater Mekong, but they also want people who are independent and not funded by anybody, so that you can represent their views and also not be influenced by the governments, which is often hard for civil society groups in these countries to be able to say what they mean, because they still live in the country themselves. So I've only been involved for a year. We are talking about how to move this forward, but the platform is just for the Greater Mekong. The other groups, as you know, would be Civil Society for Malaria Elimination, although, and one of our people is a rep for the Asia Pacific on that. It still tends to be focusing now more on Africa for good reasons from a malaria point of view. But the platform is talking about how we may be able to play some other roles moving forward. So again, happy to have those discussions.
Thank you. I'll hand over to Andrea. Thank you very much.
Thank you. Thank you, Maxine. And where can we find a copy of the Civil Society Guidelines?
Oh, well, it's not the guidelines. It's actually, I mean, I've given you, I'll pop the website up when I stopped talking for our platform. It was on the slides. Those communities system strengthening guidelines, I'll find the Global Fund link and put that up for you as well.
Thank you. Thank you so much, Maxine. Well, thank you for a fascinating talk. Obviously, you've sparked a lot of interest from people here today. And our next speaker is Professor Dennis Shanks. Dennis is Director of the Australian Defence Force Malaria and Infectious Diseases Institute. And Dennis will tell us about killing the last parasite, which I think we'll all be looking forward to.
All right. Could I have a sound test just to let me know that you're hearing me?
Yep, all good. Thank you.
All right, and a screen test. Do you see my slides?
Yes, all good too.
All right, well, very good, and thank you for this opportunity to talk. Killing the last parasite isn't going to involve stopping transmission. And I'd like to talk about that because that, in the end, is what we're really going to have to do to really eliminate malaria. As Maxine said, when you get down towards the end, sometimes people begin to lose focus and attention, and we've got to try and avoid doing that. Historically, when Ronald Ross found that, you know, malaria was a mosquito transmitted disease, everyone thought, well, this will be easy. Get rid of the mosquitoes, we get rid of malaria. And at least in theory, that was right. You know, more than 100 years on, we're finding that breaking this kill chain of parasites is a lot harder than we thought. In some places, reasonably straightforward, in others, not so much. And we've got half the world that no longer has malaria and the other half that's in the process of eliminating it. So how do we accelerate this process? How do we get to the point where there's no more transmission, where the last parasite's dead? Because what we've discovered in places like Southern Europe and in Australia is once you get rid of it, it's really not impossible to bring it back. There are scattered cases of transmission, but it's really very hard for it to reestablish itself in the ecology. The The hard road is the last mile, the last parasite. How do you break the chain of transmission and stop the next person getting infected with malaria? Well, I don't need to tell RAM that bed nets are important. Matter of fact, they've probably made most of our progress in terms of just malaria, but certainly in terms of anti-transmission and anti-vector. But they're usually good, but not in the end sufficient to take you across the line to elimination. It's not all transmission is in a household at night. A lot of it is, but not all of it. So how do you work around that? How do you find ways to do outdoor transmission? How do you find ways for people who are not in homes? The forest workers, the rangers, the people who are out in the forest at night. Do we need better bed nets? Yes, we do. And I'll mention that generally in just a moment. But also we need ways to figure out how to extend their use and how to come up with ancillary measures to account for the transmission that's occurring outside the house at night. Well, there are several ways to do this, to again block this chain of transmission, which you see pictured there. Some of it is bed nets blocking the human-mosquito contact. Some of it is drugs, which is typically what I talk about, and we'll mention some more, but we're looking at it in a broader context. What about mosquito traps, either to kill the parasites, kill the mosquitoes, or block transmission? Possible. And environmental changes. Environmental changes have made enormous impact both for and against malaria transmission. How do you encourage the positive aspects without looking at ecological degradation? This is an important question that doesn't always have a completely obvious answer. Now, bed nets seem pretty simple. I mean, as technology, they don't have moving parts, and until recently, they've only had one sort of active ingredient into the fabric. But it's a bit more complicated than that. I'll let the entomologists comment more on the technicalities, but it's basically a baited trap where you're using the human as a bait to attract the mosquito and then the insecticide in the net. Now that can kill if you're doing well, or it can repel, or it can shorten the life of the mosquito. And all of those are good things in terms of breaking the transmission chain. But again, this is only part of what it's being done. It's not just physical contact that you're blocking. You're trying to bring in the few female anophelines that are capable of infecting people and really honing in on that particular part of the transmission chain. Now, new bed nets typically mean new chemicals. And when I thought, every time I think drug development's complicated, I listen to IVCC and try and understand a bit about what their complexities are in developing new chemistry for insecticides and insect repellents. It's complicated. It's driven by commercial drivers that are at least, if not more severe than what we deal with in the drug world. And I'm really pleased to report that they've got 4 new chemicals or combinations that are in advanced testing and well on the way to new bed nets. So as much as we worry about permethrin resistance, which we should be, there are answers on the horizon. Unsure how soon they will be commercially available because, you know, the old things work, when they work, are good because they're cheaper. It's very hard to use advanced chemistry and not end up driving the cost of the bed net up. But bed nets that don't work, as we've seen in, say, recent nearby examples, when you have bed nets that are improperly impregnated, you know, they're not, they degrade your program and it loses confidence. So hopefully we do have new bed nets with both 1, 2, and new chemistry that are on the horizon, some of the names of which you see in the slide there. Spatial repellents. We've all probably used mosquito coils at some point, and we're not suggesting that everybody use mosquito coils all the time, but what about a higher tech version? Either a piece of plastic sheeting that you hang up, a small piece that emanates an aerosol, or perhaps even an aerosol can that gives a small puff of gas into a closed area, such as a home at night. There are promising results coming out of Indonesia against malaria, and hopefully soon in Kenya, where they're just getting started. Tests have been done with similar products in Peru against dengue. These are hard studies to do with the disease endpoint, and they involve thousands of people and lots of villages. But it looks like this as an adjunct to bed nets, not instead of. It has real possibilities. Again, using reasonably similar chemistry. The trick is to actually deliver it into a closed space for a limited period of time, which of course involves some sort of collaboration with the people involved. Anti-transmission drugs. Well, if we can kill what you see in the picture, which is the gametocyte, which is the transmission form of the parasite, well, then we could block transmission. And some drugs do this reasonably well. They're redox active drugs such as primaquine or methylene blue. And because of that, we tend to worry about some of the side effects with G6PD deficient people. But by and large, low doses of 8-aminoquinolines, such as primaquine, do kill gametocytes and block transmission. Now, the WHO has a policy for this. It's called single low-dose primaquine, 15 milligrams in an adult, less in children. And we know that it works, but it's been very slowly, if at all, adopted, either because it's new or because people are worried about adverse events. But it is part of what we need to consider in the chemotherapy menu in order to block transmission. What about tafenoquine, our new long-acting 8-aminoquinoline? Well, it's not cheap, and at times it's barely available. But what if you had something that looked a lot like primaquine, but it lasted for a very long time? And what if you could deliver that, pulse it through a community, and really get a turn off transmission, at least temporarily, in a certain area? Well, that's very attractive. Is it doable? Well, we'll have to see. It'll have to be tested in actual areas where you try it in communities. And as yet, we've not been able to do that. We have some opportunities. We're looking particularly at groups that go to an area and then come back, either military or otherwise, and trying to see if a pulse of an 8-aminoquinoline through a population could actually turn off transmission and possibly be used not only in terms of people who are crossing borders, but trying to eliminate it from an existing area where you have low level, but still residual parasites. And then if you can allow the mosquitoes that are still infected to die out, you lose the active sporozoite population in their salivary glands, and you have, in essence, killed the last parasite. So how might this look? Well, we need a very well-tolerated, very inexpensive mass drug administration. In the past, this has been possible in some places with chloroquine and low-dose primaquine. The infamous CP tablet that the US Army used in Vietnam for a long time wasn't terribly good against falciparum malaria, but it blocked transmission. And perhaps there is some learning from that old military experience, which we can look at, and particularly in terms of stopping an ongoing epidemic or perhaps eliminating transmission in a residual area. What about attractive sugar baits? These are being also developed by IVCC and appear to have great promise, particularly in the Sahelian African villages where they've been tested. this is where mosquitoes really need sugar and there's not a lot of alternatives. And so they tend to come to your trap better. But the theory is the female drinks blood and lay eggs, but they all need sugar from plants. If you provide an easy sugar source, both male and female mosquitoes will take that. And if you intoxicate them, well, great, you've killed them. But that is at times difficult because you don't want to kill all insects. You want to just kill mosquitoes. And that is challenging. Providing specific semi-permeable membranes work, but that carries a cost. Making sure that you have things that kids or animals that can't get into and ingest the potential toxic in components. These are all practical challenges to a very promising technology where you put an attractant in it and try and use a sugar bait trap to end transmission. Now, Darwinian evolution occurs whether we want it or not. And so if you find the perfect trap that with a great toxin and kill off the mosquitoes that are attracted to that particular version, you will clearly encourage the ones that aren't. And so is there something that wouldn't have such evolutionary consequences that would be useful? And we think if you put drugs in the sugar bait, you don't need such a permeable membrane because you're not worried about actually killing the mosquito. You're actually, or the bee or any other co-traveler. What you're trying to do is just kill the parasites in the mosquito. Methylene blue is dirt cheap. It's really safe. If it worked as a sugar bait, it would have been really interesting. It works if you mix it in blood when you feed the mosquitoes. If you mix it in sugar and feed the mosquitoes, it's not so good, probably because the iron is needed for the redox reaction. So the simple, quick, and easy didn't work so well. We're looking at other things, perhaps 8-aminoquinolines, perhaps combinations. But
excuse me, Professor Dennis, we have 2 minutes left.
Finishing up. All right, mosquito unfriendly environments. What we noticed in Thailand was if you cut down all the trees, the malaria went away. That's not necessarily a great thing. Landmines were actually promoting malaria in some places. But if you cut down the trees and planted cassava, you didn't get malaria. If you plant fruit trees and the mosquitoes come back, well, then you got your malaria back. So how do you do this? That's probably a level of complexity beyond what we can discuss, except to say that you need to really look carefully at anything that brings in new agricultural or forestry practices, because it can easily disbalance your malaria program. We'd like to have something we could use in mobile populations. The old CP tablet, single dose, give it to people when they cross the border would be great. And maybe there are options for that. Venezuela seeded a great deal of the Amazon. Burma is clearly going to be an ongoing problem for malaria transmission. Would love to have a drug that we could safely give to people on a single dose that would block transmission. And we have hopes of developing that in the future, but we're not there yet. So can we block transmission? Yes. Can we kill the last parasite? In theory. Do we have to do it all in conjunction with the community and the ecology? Absolutely. So we're starting where we knew we would end up. No single magic bullet's going to do this for us. We're always going to be dependent on bed nets and their next generation. But we're going to need drugs. We're going to need ancillary measures, and we're going to need, and hopefully some of the few that I've mentioned to you today will actually be helpful. Thank you, and if there are any questions, I'd be glad to try them or refer them to a more competent entomological colleague. Thank you. Oh, and yes, we do. I don't want anyone to think that I do this all by myself. I don't. Multiple collaborators in multiple places. Thank you.
Thank you, Dennis. Well, there are a number of questions that I've come through. Ash is asking where bed nets are made generally. I understand that the WHO coordinates and pre-qualifies products. But what is generally,
well, like
I guess,
everything else, most things are manufactured in China and possibly India. And certainly when you're talking about chemistry and chemicals and drugs, that's also true. It's very hard to be lower cost, although there are some local productions in Southeast Asia that do textiles well. The problem is bringing it all together. If you just want a bed net, that's one thing. If you want an impregnated bed net or a well-impregnated bed net or a well-impregnated pre-qualified bed net, well, you know, that does get complicated. But the same people that supply the world with other industrial products are also the same ones that make bed nets.
And my understanding is that the Global Fund is responsible for a lot of the distribution of bed nets to countries that need them, but I'm not sure about generally how the system works. How do we make sure that needy countries and people get access to the bed nets and the drugs that they need?
How things get funded is often a complex thing. I think I should probably defer to my colleagues that run the RAM system in Papua New Guinea, if they've not already talked. They have numerous stories about the challenges of remaining funding and delivering needed products. And we're not even talking about second or third generation. We're just talking about ordinary bed nets. I'm afraid that anything I say on this would either be dated or potentially inaccurate, except to say that it's a challenge. Getting anything delivered across borders during a pandemic is very difficult. They've done well considering, but there are a lot of gaps, you know, in our, you know, vaccine, just ordinary vaccine programs, ordinary anti-malarial programs that have come up because of COVID that we're going to be having to work our way through here for some time yet.
Thank you. Yes, Tim Freeman is talking tomorrow about PNG, the program there.
I think you should listen to Tim more than me.
Listen to you and Tim. Also, a question that, as Tony Maple has indicated, may be a bit big to go into today, but what's the impact of global warming on mosquitoes and malaria?
Well, certainly there is an impact. I mean, in terms of what happens, but in terms of a big change, in terms of moving malaria around the world, very little. You know, we've looked for it hard, and me especially in highlands of East Africa, where you'd think that this stuff would move up and down the altitude curve as things warm. But by and large, I'm not a global warming denier. It is important. I know COP26 is going on, but for malaria, we've got some bigger challenges that we do have a grasp of. So is global warming affecting things? Yes. Is it making a big difference to what we do day to day? Not really. I think our concentration in malaria needs to be on the things we know and the things that we're going to have to deal with. And in some niches, things will change. But in the places that I expected to see the most change with global temperature changes in East Africa, the problem was actually drug resistance more than any ecological change.
Thank you. And one final one, are there international standards for LLINs?
There are, but again, the market dictates what actually happens. So WHO tries to have, you know, set the standard and the bar, and IVCC is trying to keep ahead of this so that when one product fails, we do have something to go for. The hope is that we can deliver high quality bed nets across large areas, and when we need them, go to more expensive, newer products, because so we learned with the chloroquine story, if you keep distributing something because you can afford it, but it isn't working, people lose confidence in your program and you don't really achieve your outcome. More money is sometimes what you have to pay, even to a relatively low-tech intervention like bed nets, because when you distribute them to an entire population, it's necessarily an expensive proposition.
Thank you. Okay, and I think we're back on time at the moment. So thanks very much, Dennis. That was a fascinating and stimulating presentation.
Okay. Can I just check that you can hear me and see me? And
can
see the
hear
slides?
you. Yes, the slide. If you can, I don't know whether you can go to slideshow, but
maybe go to slideshow. Hang on. There we go. So thank you very much. My name is Caroline Lynch. I'm with MMV. I'm going to talk to you today about the Partnership for Vivax Elimination. So just to give you an overview of what I'll go through today, so I'll talk about what PAVE is, a Partnership for Vivax Elimination.
Sorry, Carrie, the slides seem to be sticking. We're still on the first slide. I don't know if you've moved to the next one.
I've just moved. Is that working?
No.
Oh, it's saying resume share. Here we go.
Can we have a slideshow, Carrie? Thank you.
Honestly, this is always
I know, isn't it?
Perfect.
That's
perfect.
great.
Has it just moved on? Okay, sorry about that.
No,
Technology,
thank you.
Yay. Okay, so I'll talk about what PAVE is, what we're doing in the Asia Pacific, the plans for work in Indonesia and PNG, and we can discuss what support we can offer RAM and vice versa. So first of all, to who PAVE are, we started off as a relatively small, I guess, alliance between PATH and MMV. PATH are responsible or have been working with manufacturers to develop a G6PD analyzer test. And G6PD is an enzyme which, if people are deficient in G6PD and they receive an ataminoquinoline, which Dennis referred to earlier, it could cause hemolysis. So testing a patient who has Vivax malaria before they get treatment is best practice. MMV have been involved in developing kind of the last stretch of tafenoquine. That was a drug in development for a long time with a lot of investment from Australia and work from the Australian Army as well. So that initial alliance then was then expanded out this year with some more funding. And we brought in partners such as Burnett and Menzies, who I'm sure you're all very familiar with. And then we work with these other organizations across the region as well. Just to highlight, and I'll speak a little bit to ATMEN Vivax Working Group, the Asia Pacific Malaria Elimination Network Vivax Working Group. MMV is hosting that for a couple of years now, and I'll just speak a little bit about that work as well. It pretty much aligns with the PAVE work. So in terms of PAVE, really, and quite simply, as you all are trying to do, we're trying to help countries support achieve their elimination targets. And we're trying to do that by generating high quality evidence for use by decision makers, both at the national level and perhaps also at the global level. We're also supporting governments to improve their Vivax radical cure. And I've kept that quite broad for a couple of reasons. One, to just explain that when we're talking about radical cure, and this is the drug given to treat the liver stage of Vivax parasite, which is a stage that is complex to treat, but we're talking about any and all tools that can treat that stage. So trying to improve the coverage of all of the tools. So the currently recommended treatment is primaquine over 14 days. So you give that with a blood stage cure, so the Artemisinin-based combination therapy or chloroquine, to try and kill the hypnozoite stage, the sleeping stage of the Vivax parasite. We're trying to work with programs at the moment to improve the coverage of that treatment, but we're also trying to work with programs to get ready for these new tools that are emerging from the pipeline that could potentially make that job of killing that part of the parasite easier. So we're trying to work on all aspects of the Vivax radical cure. To that point on the new tools, I just wanted to give you an update on where we are with some of those. So we have a higher sensitivity rapid diagnostic test. So at the moment, there's a rapid diagnostic tests that are available which are sensitive to picking up falciparum malaria, but not so sensitive in picking up Vivax malaria. Now there are new tests coming on stream, one of which is the Rapigen Biocredit, and that's more sensitive to picking up the Vivax parasite. So we'll be able to better detect Vivax in patients that are coming to health facilities or in people who are asymptomatic in the community. That test is expert review panel on diagnostic approved by the Global Fund, and that means it's procurable under the Global Fund grants at the moment. There's a semi-quantitative G6PD analyzer, which I think both Camilla and Dennis mentioned earlier, and this is a new and pretty exciting tool that allows us to now measure G6PD enzyme activity at a lower level of the health system. So rather than having to do work in a lab in a hospital, we can bring this closer to the patient. This is also ERPD approved and procurable under the global funds. We talked a little bit about the WHO pre-qualification processes for the vector control tools. This is submitted to the WHO pre-qualification process, but that has undergone significant delays because, as you can imagine, with COVID and trying to pre-qual a whole load of those tests. So currently we're estimating that it will be approved in Q4 of 2022. The next set of new tools, and perhaps this isn't so new, PQ 7-day, there's been work published on that a couple of years ago now. So obviously if we move from 14 days of treatment to 7 days, then we're hopefully immediately increasing adherence to that drug. As you can imagine, getting a patient to take that treatment for 14 days is challenging. There's also work that's coming out pretty soon. The results will be published soon on Primaquine 3.5 days. And that's work coming out from Papua New Guinea with Curtin University. Finally, Dennis mentioned adult tafenoquine. So we're going from the current dose from 14 to 7 days to 3.5, and tafenoquine is a single dose radical cure. This must be used with a semi-quantitative G6PD analyzer. That's a constraint of its use. And the reason for that is because obviously it will cause hemolysis in patients, or could cause hemolysis in patients who are G6PD deficient. And so we need to know the patient's enzyme activity before they're administered this drug. It has been approved by FDA and the Australian TGA for use with chloroquine only at the moment. At the moment, the adult doses for 16 and above, and the pediatric tafenoquine dossier is under review by the Australian Therapeutic and Goods Agency, which would allow for its use in under 16s, and that we expect the approval out hopefully next year. So moving on to talk about what PAVE are doing in the Asia Pacific. I'll just show you globally where we're working, and then you can see from that a lot of our work is focused in the Asia Pacific. These are our priority countries, and at the bottom there you'll see the kind of 5 phases that PAVE think about when we're talking about trying to improve radical cure in these countries. And obviously these countries are selected because of the Vivax burden, and that's our key focus. So what we try and do essentially is, and I hate the word market, I prefer whole health system approach, but anyway, we try and understand the situation, both epidemiologically in terms of Vivax and G6PD, deficiency prevalence, but also the health system, the regulatory pathways, the procurement pathways in a country. And then we try, and this is relevant obviously for new tools, and then we try to work with national programs to really emphasize and put a focus on how they can tackle and improve their Vivax radical cure. So we come up with strategies or readiness plans to do that, either to improve what they're currently using or to prepare for new tools to come in. Then we talk about market entry, which is basically trying to get to implementation and scale up. The darker colours that you see in those countries signify the countries that we think will get to implementation by the end of the project, which is 2024 at this stage. And the lighter countries are where we're really aiming to try and get to some level of policy change to bring in new and better tools, hopefully, with countries. So not to go too much into the weeds on that, but just to tell you that we're trying to get, we estimate, and perhaps this is a little bit of an underestimate, but we estimate that currently maybe 15% of patients in those countries are receiving a proper full course of radical cure for Vivax malaria. And we're trying to push that up to higher coverage. The blue circle and the orange that you see there for me to remind me to tell you that I think of ourselves as catalysts or enzymes to try and accelerate activities forward in this space. So to that end, what we do is, as I said, try and understand the situation. We work all the way from the regulatory side of things down to implementation. Dennis referred to, the fact that spinaquin is rarely available at the moment, and that's primarily because of these global and national processes that require approval of the drug, further implementation research on it, and so on. And Maxine referred to the importance of communities, and what we are very cognizant of is that these are complex tools. Even if they're exciting and allow us to make a step forward, they will rely on communities being able to use them, and how they can use them is a question in our minds at the moment. So we're working on that whole gamut of things, from regulatory down to implementation, and in the middle, policy change. Just to kind of highlight some of that, we work with countries, for example, to generate and then collate evidence. So if we find, for example, a national program has a key question about something that we can help them with, we will pull together all and any evidence on that question to enable them to make that data accessible to them. And for example, in Myanmar, before the current situation, the national program had queries from within the Ministry of Health as to whether G6PD deficiency was actually a problem in Myanmar. And so what we tried to do was help the national program by pulling together all of the studies on G6PD deficiency in the country and providing that in an accessible brief for them to base their decisions on and have more informed decisions. And we're also trying to document early use of these new tools so that other countries can learn from the kind of experiences, what worked and what didn't work. For example, in Cambodia, Laos and Thailand, where the quantity G6PD is being used now. Just to flag, for the ATMEN Vivax working group, our overall goal for the Vivax working group is, obviously, our remit is beyond just the Greater Mekong subregion where I'm based, and extends across the Asia-Pacific region. But it's pretty much aligned to the PAVE goals, and that is to contribute to countries achieving their elimination targets. And in doing that, what we're trying to do is accelerate the uptake and implementation of optimized radical cure. Just an example of what we're doing, we're trying to emphasize putting emphasis in higher burden countries and doing readiness planning. And that's basically working with programs to figure out what the bottlenecks would be if they wanted to change policy and how we can address those bottlenecks now. So we're just trying to create a smooth road for the quicker implementation and quicker uptake of new tools that could help them eliminate malaria. We're also working with countries to identify what their key priorities are related to that readiness planning as well. And we're actually doing this across the national malaria programs in the Greater Mekong subregion at the moment. So we're listening to them to let them tell us, okay, well, these are the key questions in our minds that we feel need to be addressed in the next 12 to 24 months in order to kind of make a move to either new tools or improve the tools that we have currently. And we're also doing this with a number of countries across the Asia-Pacific region, including Solomon Islands, I think in November, and PNG in January next year. I'll talk to that in a second. We're promoting cross-country learning. So again, often if a country sees someone else's experiences in using a new tool, that might get them to think more about taking that tool up. So we're doing that through the Vivax Working Group annual meeting, and we have these tech talks where we try and highlight and bring to attention different mechanisms that countries are using to get to various problems. I think the next one will be on patient adherence to the PQ 14 day. And we're also happy to provide technical support. We've developed training materials for studies that we're going to be undertaking. We're developing an options assessment toolkit to help national programs decide now between all of these new tools that are suddenly becoming available after only having PQ 14 for 60 odd years. So we're trying to support the decision making it as informed as possible, and then providing support to ensure that implementation is of higher quality as possible. And then we do liaise quite closely with major funders. The global funds have been mentioned a lot. We talk to DFAT and update them quite regularly, and Gates. And in terms of those priorities that we identify from programs, if there's stuff that's outside of our remit, we advocate to the donors and kind of give them a heads up as to where their resources may be better allocated. And we also talk to research partners and people like yourselves to say, these are the priorities coming up for national programs. if you want to kind of tweak what you're doing to address some of those.
Dr. Carrie, just 2 minutes left.
Okay, thank you. In terms of work for Indonesia and PNG, this is under the generating evidence category, and we've got feasibility studies planned and being prepared at the moment to look at the feasibility of using primaquine 7-day with the quantitative G6PD analyzer, and that's higher dose primaquine 7-day. This mirrors other studies that will be taking place across both the Asia Pacific and globally. And in other countries, we're looking at the feasibility of using the quantitative G6PD analyzer and tafenoquine. And underway at the moment, which is really exciting, Brazil started this year looking at tafenoquine and the quanti G6PD analyzer, and they've already recruited enough patients for the preliminary analysis. Thailand, the protocol is approved, and we're just waiting for the COVID situation to ease to move on with that study. Those feasibility studies will be looking, when I talk about feasibility, is how, can health workers use these new tools and down to what level of the health system? Bearing in mind they can be quite complex, can we get them to where the caseloads are highest is key in our mind. We're also looking at acceptability and cost, not just of the tools, but also all of the support interventions that have to be in place for them to be integrated into the health system. In Indonesia and Papua New Guinea, they're going a step further and they're looking at the impact. So what's the impact on Vivax incidence of introducing this package of interventions? Very quickly, I've kind of spoken to this broadly, but we're planning readiness planning in Papua New Guinea in early 2022. And that, again, is to try and talk to the programme and get some emphasis on Vivax and see what they need to do now to be ready for bringing new tools on board when they're ready to do that, or how they can improve what they're using currently. Beyond Vivax, I'll very briefly mention this just because you're probably aware of it. MMV are supporting the Lahir Malaria Elimination Project in Lahir, PNG with Newcrest and a number of partners to eliminate malaria from the Lahir province. And that's undergone kind of some significant delays, but they are re-strategizing on a way forward for that soon. And finally, what support can we offer RAM? This is my final slide, and vice versa. As I said, we can help share lessons from other countries and also learn from what you guys are doing as well, and bring that across to other countries so they can learn. We have expertise, there's me here in the region, but we've got a whole team. Camilla was talking about DFAT supporting MMV. Our R&D team are working on, for example, resolving how to use TQ with ACTs. Obviously, we're very closely connected with Menzies and Burnett, as you probably all are as well, to talk about PQ7. And we're talking to PATH on a daily basis about the diagnostic tests that they're involved in developing and working on. So I think we've got some expertise to complement RAM's own expertise on operational implementation research. For us, what's very, very valuable is our conferences like this, getting updates on the challenges faced by countries so that we can try and help move things along where we can. Providing linkages with national programs and helping us to understand the context, not just the technical context, but the political and economic context, which I think is quite key because we forget that side of things when we're talking about malaria, and actually that can often impede malaria progress more than the technical side of things. So with that, I'll say thank you to our partners, to the funders of the PAVE work. Obviously, I present a whole team of people, and so a big thank you to them. And I'll just leave on this page, which is the vivaxmalaria.org website, on which there's a lot of resources, including a study database. And I wanted to flag, because I know that RAMs support PhD students, the Vivax, the International Conference on Plasmodium Vivax Research is coming up in April. The registration is open, and abstracts can be submitted up to January 12th. So I'd encourage anyone who's got research going on to submit to that. Thank you very much.
Thank you, Caroline. Oh, fascinating talk. Obviously stimulating a lot of interest. And I know that Jenny Kerrison has a number of questions that she is burning to ask you.
Thank you, Carrie. Really good of you to participate and join us all the way from Thailand. And thank you for a very interesting presentation. I guess one of my questions was looking at your slide in regards from the time of marketing landscape to scale up. And I think, well, having followed a few of the admin tech talk, it seems a long process, but in your estimation, how long does it take? Because, we're targeting malaria elimination for some countries, 2030, and just wondering, how do we speed up that process? Thank you.
Yeah, that's a key question. Thank you. There's actually a really good presentation that I can share the link to by Veronica Ruanpura, who's working on this. And the estimates are, it can take sometimes up to 17 years to get from when evidence emerges to implementation. And I would argue that we don't ever really get to full implementation if you look at kind of coverage of tools. So it takes a long time, and we're trying to accelerate that progress by doing this readiness planning with national programs. So rather than, for example, a WHO recommendation coming out to programs and then them registering a drug, then having the national policy change processes take place, which can take up to 3 years sometimes from the studies that we're doing. We're trying to almost squeeze that without losing the rigor, but trying to figure out where we can gain time to work with countries to generate the evidence now, register the drugs to allow for feasibility studies rather than clinical trials, work with programs to say, okay, if there were massive procurement delays in the past, how can we mitigate that in the future with these new tools coming in? If there were significant delays getting a signature on a policy, how can we get ready to do that as quickly as possible the next time? So that's how we're trying to accelerate things with national programs, through this more proactive approach. As at the global level, WHO are considering the new tools and developing guidance on them.
Thank you very much. And I think looking at what we're doing in West Timor, we've actually initiated the introduction of community health volunteers or village malaria cadres, which is a specific regulation in Indonesia, not allowed unless it's a remote location. And we've managed to initiate that at the border areas, at the international border with Timor-Leste. So I think, we're trying to look at areas where Rotarians can be helpful, and being a neutral partner with no political ties. I think we have an added advantage, and we also have Rotarians in country. So Carrie, thank you very much. It's terrific, and I will definitely catch up with you and with several of our members to talk further. Thank you. Thank you very much.
Thanks a million.
Well, thank you. Thank you, Caroline, for your talk. And I think that seems to be about it for questions. And that concludes today's session. So on behalf of Rotarians Against Malaria, I'd like to thank all of our speakers, Jenny Kerrison, John McLaren, Camilla Burkot, Maxine Whittaker, Dennis Shanks, Danielle Stanisic, and Carolyn Lynch. And thanks to Natanya and Gloria for ensuring a smooth operation. I thank all of you who've participated in episode 1 of our RAM National Conference. We look forward to having you all online again at the same time tomorrow for part 2, which promises to be another interesting and stimulating session. Now, look, please stay online to watch the winning video from the 2021 RAM Annual Schools Malaria Video Competition. It's only a couple of minutes long, and it will leave you smiling. And that's goodbye from me.
Creo que todos necesitamos hablar de malaria. El mundo tiene que saber qué es malaria. Yo no lo sabía, pero lo aprendí y se los explicaré. Es una enfermedad que me pone muy mal, causado por un pequeño parásito, así de chiquitito. Se llama plasmodio. Pero la enfermedad no tiene nada gracioso, me da escalofrío. ¿Sabe cómo se contagia? Con una picadura de un mosquito. Te puede picar cualquier parte del cuerpo y te puede dar ganas de cascar. Si a la mamá le pica, el niño también se puede contagiar en la barriga. Yo soy de Pacífico de Colombia. Hay mucha naturaleza. Cuando estamos dormidos, tenemos una malla que nos protege. Para que el mosquito no se introduzca, hay que sacar todo el agua estancada. Si me siento mal, tengo que ir al médico. hacer un científico loco. Con un par de pruebas podemos ver si es malaria. Esta prueba que vamos a ver por un microscopio una gotita de sangre para ver si está infectado. Para curarte tienes que comer bien, tomar agua, tomarte todos los medicamentos y así no te vas a enfermar. ¡Chao, malaria! ¡Chao, malaria!